Thanks, Richard, for the introduction, and thank you to everyone for taking time out to join us today. So my charge in the next 15 minutes is to talk about atrial fibrillation and what it is. Um, uh, the objectives are, in the next few minutes, are to talk about what is atrial fibrillation, why it matters, and give you a brief overview about how atrial fibrillation is treated. So atrial fibrillation is the most common arrhythmia globally. Normally, the heart has top and bottom chambers. The top and bottom chambers beat in sync, with blood flowing from the top chambers through the valves to the bottom chambers. Atrial fibrillation occurs when the top part of the heart beats in a very erratic or unsynchronized fashion. This results in variable blood flow from the top to the bottom chambers of the heart. It can result in the heart beating too fast or paradoxically too slow, and this lack of contracted organized activity can result in symptoms. Again, this is the most common arrhythmia globally. It's estimated that around 3 to 500,000 Ontarians have this, but this number is just an estimate because many people aren't aware that they have this problem. Atrial fibrillation is classified based on the duration of the arrhythmia. Paroxysmal atrial fibrillation is atrial fibrillation that starts and stops on its own. Typically, patients have periods of normal rhythm and then these paroxysm of symptoms due to the irregularity. Persistent atrial fibrillation typically occurs when the arrhythmia has lasted a longer period of time. And in general, this is an arrhythmia pattern where the arrhythmia starts and typically does not stop on its own spontaneously. In situations like this, drugs or electrical cardioversion, or otherwise known as a shock to the heart, are needed to restore normal rhythm. And finally, permanent atrial fibrillation is a situation where someone has this arrhythmia all the time, and the decision is made not to do anything about it since they seem to tolerate it relatively well. In terms of the causes of atrial fibrillation, there are electrical and structural changes to the top portion of the heart. It's these electrical changes which provide the substrate for this arrhythmia to occur. In certain situations, triggers can occur that can result in atrial fibrillation. We don't really know what causes atrial fibrillation, but there are some situations which are associated with the arrhythmia. Age is probably the most common risk factor for atrial fibrillation. As you get older, many patients get progressive structural changes to the heart which predispose them to this arrhythmia. There is a genetic component to this, but we don't know what the genetics are specifically. We know that patients who have a parent with atrial fibrillation, they tend to have a higher risk of having atrial fibrillation compared to those without a first-degree relative with atrial fibrillation. But we don't know how to modify these genetic risk factors, and we don't know all of the genes that contribute to this. Other medical problems can contribute to the arrhythmia. Lung disease, renal disease, heart failure can all play a role in atrial fibrillation. Patients who are overweight also have an increased risk of atrial fibrillation. And indeed, weight loss has been shown to decrease the frequency and burden of atrial fibrillation. Thyroid dysfunction is a condition which is a reversible cause of atrial fibrillation and important to recognize in patients. Then there's some lifestyle factors that contribute to the arrhythmia. Particularly, alcohol is one potent risk factor. And we know for every additional glass of alcohol that one drinks, the risk of this arrhythmia increases. Indeed, there are situations where one can binge on alcohol and have a phenomenon called holiday heart syndrome, which is where we frequently see these arrhythmias at the time of holidays such as Christmas or New Year's. Although weight loss and exercise can definitely reduce your risk of atrial fibrillation, it's well known that excessive exercise can increase that risk. And we often see this in young, high-level endurance athletes who have atrial fibrillation despite not having other risk factors for the arrhythmia. Diagnosing atrial fibrillation is not easy, and the gold standard is having an ECG recording showing this irregular abnormality within the heart. This is a tracing where you see on the top level, you have this irregular undulating fibrillatory pattern in the atrium, which is the low amplitude signals. And this is a tracing of normal rhythm where you have a nice atrial activity prior to every ventricular activity. So instead of that irregular heartbeating, you have a nice regular heartbeat with organized activity prior to each contraction of the heart. So to have an ECG, you need to know when to have this ECG. And many patients don't have symptoms, so they're never prompted to actually seek out attention to obtain documentation of this. We frequently screen with ECGs in patients who have symptoms of palpitations, shortness of breath, extra heartbeats. Patients with stroke, we often screen them for this arrhythmia given that it is associated with stroke. And if you have any of the other risk factors that we spoke about, we tend to have a more vigilant approach to patients to screen in this situation. You as a patient can screen yourself by doing pulse checks. Simply placing your fingertips on the radial aspect of your hand, you can palpate the pulse, and you can get pretty good at telling when your pulse is regular and irregular. Dr. Chung is going to talk about commercially available devices, but there are many devices out there on the market right now where you can test for atrial fibrillation. Gizmos such as the Cardium Mobile, which sync to your smartwatch or so your iPhone or your Android device, can give you a tracing of the ECG. And commercially available blood pressure cuffs also have algorithms in place to help you detect if you have this arrhythmia. If you are diagnosed with atrial fibrillation, there are other tests your doctor may want to do. Blood tests such as thyroid level measurements are important to ensure that you do not have a reversible cause of atrial fibrillation due to hyperactive thyroid. And as well, your doctor may want to look at your kidney and your liver function, as different therapies that we use to treat atrial fibrillation are impacted by your kidney and liver function. Your doctor may want to obtain an echocardiogram, and indeed, nearly all patients who have atrial fibrillation get screened with an echocardiogram to look for causes of atrial fibrillation, such as valve abnormalities, or consequences of atrial fibrillation, such as the development of a weak heart. Holter monitors are frequent tests that are employed by your doctor, and this is done to help your doctor understand the burden of your arrhythmia and help them obtain correlation with your symptoms to know that it indeed corresponds to atrial fibrillation. We know that sleep apnea is associated with high blood pressure and also atrial fibrillation, so your doctor may ask you to undergo a sleep study. And finally, some of the therapies that we use to treat atrial fibrillation are impacted by other cardiac conditions such as coronary artery disease, so it would not be unusual for your family doctor to screen for other coexisting heart disease. In terms of the consequences of atrial fibrillation, one of the main consequences are symptoms or what patients feel. And your heart doesn't always pump out of your chest when you have atrial fibrillation, but that is the most common symptom that patients have: palpitations or fluttering in the chest. But other symptoms can exist with atrial fibrillation, such as vague symptoms of chest pain, shortness of breath, lightheadedness. But a lot of patients have no symptoms at all. And this makes it challenging to make the diagnosis and understand the burden of the arrhythmia. Other consequences of atrial fibrillation are healthcare consequences or bad things that can happen to you when you have this arrhythmia. Stroke is one thing that we worry about the most, as patients with atrial fibrillation have an increased risk of stroke. The rate of stroke is around 4 to 6%, and that's generally higher than the population without atrial fibrillation. That risk of stroke is further increased in a patient who has AFib when other healthcare conditions are present, such as older age, the presence of heart failure, high blood pressure, diabetes, or if you've had a stroke before. Heart failure is another consequence of this arrhythmia, and this can happen in the setting of a normal heart, where the absence of normal contractile activity between the top and bottom chambers results in blood backing up into your lungs, making you quite short of breath. But in some patients where the heart rates are very fast, you can get a weakening of the heart muscle and a weak heart pump function. While those are the extreme consequences of atrial fibrillation, a large number of patients actually do well and have no adverse health consequences as a result of having this arrhythmia. Our treatment is aimed to improve symptoms and decrease the risk of adverse consequences such as stroke. Our primary approach is to reduce the risk of stroke. And this is important because stroke associated with atrial fibrillation is often worse than regular stroke. Okay. In general, patients who have atrial fibrillation, they require some sort of therapy to reduce the risk of stroke. And that need for therapy is highest in patients who have risk factors such as diabetes, high blood pressure, a weak heart, or who are elderly. In general, patients who are more than 65 years of age who have this condition warrant therapy to reduce the risk of stroke. Our most common way to reduce the risk of stroke is using blood thinners. And this ranges from the old school blood thinner warfarin, which many of you know as rat poison, to newer blood thinners, which are much easier to take. What these blood thinners do is they thin the blood generally, but there's a little outpouching of the heart called the left atrial appendage where these clots tend to form preferentially. And the hope is by thinning the blood and preventing clots from forming in this area here, you can reduce the risk of stroke. There are newer non-drug approaches to prevent stroke that capitalize on the fact that we plug up this little area where the clots form. And these are left atrial appendage closure devices. And we use them in patients who generally cannot tolerate oral anticoagulation due to risk of bleeding. Your doctor may want to treat your arrhythmia by slowing down your heart rate because frequently a lot of the symptoms are due to fast heart rates. So it would not be unusual for your doctor to consider drugs such as beta blockers, calcium channel blockers, or digoxin. While we want the heart rate low, we want to avoid too low heart rates because there are obviously bad things that can happen with very slow heart rates. So at a minimum, we want to ensure your heart rate most of the time is less than 110 beats per minute. Very rarely, there are patients where we cannot achieve slow heart rates with the use of these pills, so they may require a pacemaker and a simple procedure called an AV node ablation, which allows the pacemaker to regulate your heart rate. There's some patients where just simply slowing down the heart rate is not sufficient to control their symptoms. In this situation, we want to maintain normal rhythm. And there are two main approaches we use to maintain normal rhythm. One is using drugs, the other is an ablation. There are many drugs that are available on the market to treat atrial fibrillation. In general, these drugs work in about 40 to 50% of patients, and they have varying side effects, some which are nuisance side effects and some which are life-threatening. Ablation is a non-drug way of trying to control the arrhythmia. And again, there are various modalities to treat this, such as burning the heart, freezing the heart, and other different technologies, including surgical technologies. It is slightly more effective than drug therapy, and studies have shown that about 50 to 80% of people will have a good result after an ablation procedure. Much like drugs have side effects, procedures have risks, and some of these risks are life-threatening. When you look at comparing drugs to ablation therapy, we know that with ablation therapy, because it's a bit more effective, there is an improvement in symptoms compared to drug therapy. Patients have fewer hospitalizations. And in some patients, particularly those with a weak heart and symptoms of heart failure, they may actually live longer. Once the diagnosis of atrial fibrillation is made, it's important to recognize that this is a chronic condition and you'll be living with it for the rest of your life. So you will need routine follow-up and routine care to ensure that nothing has gone wrong. Your doctor will want to keep an eye on your heart rate intermittently, assess the burden of your arrhythmia. For patients on blood thinners, blood tests will be done intermittently to ensure the safety of ongoing use of these blood thinners. Any changes to your health, such as the development of new conditions, will impact the treatments that we use for atrial fibrillation. And depending on your symptoms, which may change with time, there may be a need to escalate therapy. Atrial fibrillation is evolving, and we do research to ensure that patients are receiving optimal care. And here at Sunnybrook, we're fortunate to be involved in many studies looking at improving the care of patients with atrial fibrillation. We're currently doing work looking at using a registry to study the risk of stroke in patients not on blood thinners. And this is important for us to ensure that the risks of stroke that we've quoted based on older data still persist. Dr. Chung and myself are co-investigators on a study looking at a newer blood thinner, which has a lower risk of bleeding. I'm collaborating with my interventional cardiology and neurology colleagues looking at the combined use of blood thinners and left atrial appendage closure devices in patients with AFib to see whether or not this double approach has a reduction in the risk of stroke compared to just using blood thinners as we traditionally do. Dr. Chung will be spearheading a new study to look at a new tool to screen for atrial fibrillation soon at Sunnybrook. As well, our work goes beyond the clinical work, and Dr. Terry Cabras has an active animal lab where she evaluates new tools that we will be looking at using for clinical treatment of atrial fibrillation down the road. So in summary, atrial fibrillation is very common. Screening is important. There are many ways to treat atrial fibrillation, which require conversations with you and your healthcare practitioner. And we do research at Sunnybrook to try to improve the care of patients with this arrhythmia. With that, I'd like to thank you for your attention.